Good morning, everyone. Welcome to today's CCR. It's being conducted by Department of Endocrinology, and uh, with the in the interest of time, I'll just go through the department introduction little quickly, if sir permits. So, the department was started in 2015, 10-year back. Then the formally it was started in 2022, that is 3 year back, and then we also started in the same year the DM program in 2022. In fact, the first batch was recently passed out in 2025. So we have 2 students per year, and right now we have 4, and we are hoping that in next month or so the new batch will join. So endocrinology is deals with a wide array of disorders and involving various organs. So we fortunately we as a department are catering to all the as a whole 360-degree spectrum of endocrinology, which includes diabetes, thyroid, and other complex endocrine disorders, pituitary, adrenal, reproductive endocrinology, and bone mineral disorders, and as well as we have a decent number of pediatric endocrinology cases also. And gradually the strength of the OPD and in terms of numbers, in terms of variety of cases, is going up, and that is why we are running specialty clinics also in different days. We try to allocate a particular day to our patients so that we can give more specialized care to these patients, and at the same time we are trying expanding the facilities. We are catering a decent number of patients who are on pumps and all, and diabetic foot is one of the area of interest, because saving one limb is actually saving one life. That is what we talk about in diabetes. So we focus on more of a prevention of diabetic foot. And just want to take 1 second here. So we have DEXA machines for like last few years. Just want to tell everybody and use this opportunity. Recently we have acquired the TBS software, that is trabecular bone score, which is the probably first time in private setup, or in fact in other than Jodhpur AIIMS, as far as I know. It is not available in Rajasthan. And what it gives us, it tells us that not only the density but the structure of the bone can be also decided by this thing. So a patient may be having normal BMD. As you can see, these two BMDs are same, but we can see the difference in terms of quality of bone. The upper one appears to be normal, and the lower one is there is significant loss of architecture. So I would request that especially when we are dealing with steroid-induced osteoporosis, or for oncology like androgen deprivation therapy, or hormonal therapy for breast cancer, we should always ask for TBS, and it is now available in our center. Endocrinology is all about interdepartmental collaboration, and we are very much linked with the most of the specialty branches, whether it is neurosurgery, where we treat pituitary patients, urology, where we treat our adrenal patients, and then of course endocrine surgery, head and neck surgery, where thyroid, parathyroid comes into picture, and then GI surgery and hepatobiliary surgery, where we interact in terms of pancreatic neuroendocrine tumors. And जी sir, yeah. And as I said that it's all about interdisciplinary collaboration, and that is why we have expanded the facility in terms of hormonal assays, and we have a very good support from nuclear medicine team, molecular genetics, oncopathology, because without which endocrinology will not be able to function to this full strength. And then again, this is again I want to highlight, this is probably one of the very few centers in our country where we are doing all kind of high-end endocrine diagnostic procedure. Other than few INIs, it is not being available. So that is one thing which I am thankful to management that we are doing it here, which includes IPSS, AVS, and
क्या बोला राजीव, कौन-कौन सी चीजें अवेलेबल नहीं है?
INIs like PGI, AIIMS. Other than that, JIPMER, CMC, there are 4 or 5 institutes in the country where we do these kind of testings.
What is lacking now? You said something.
No. What I am saying, sir, it is available in our institute, and which is again a very rare phenomena in terms of all availability of all specialty. It is available only in, like, we can count the centers in the country where these procedures are being done. So, and then there is a good amount of academic output is there, and then as I said, it is about all interdisciplinary learning and integrated clinics. Our focus is on that. And today's case will actually highlight how in a close communication, interdisciplinary meetings can actually change the outcome. So with this, I will invite my first year resident, Dr. Harmanpreet, to present our case and take the proceeding further. Thank you.
A very good morning, respected Chairperson, sir, faculty members, and my colleagues. I am Dr. Harmanpreet Singh Batra, first year DM resident from Department of Endocrinology. Today, I will be presenting a case titled A Long Journey of a 32-year male with crippling and mysterious disease, under the guidance of Dr. Rajiv Kasliwal sir and Dr. Saloni Jam ma'am. Patient is 32-year male, mechanic by profession, 10th, educated for 10th standard and resident of Jaipur, presented with complaints of progressive low limb weakness for 5 years, generalized body pain for 5 years. He also had difficulty in walking for last 1 year, and over 5 months his condition deteriorated to the extent that he became confined to bed. Patient was apparently well 5 years ago when he began noticing weakness in his lower limb. The weakness was insidious in onset, gradually progressive, initially predominantly involving the proximal muscle of the lower limb, particularly the hips, thighs, and later progressed to upper limb as well. Over time, he developed difficulty rising from squatting position, followed by difficulty in climbing stairs and performing overhead activities. In addition to his weakness, he also complained of diffuse generalized body pain for past 5 years, which was insidious in onset, gradually progressive, predominantly involved the proximal region, especially the lower limb and the shoulder girdle. He described this pain as dull, deep aching pain, which worsened on weight bearing and movement. Over the past 1 year, his symptoms progressed to the extent that he required support for walking and performing daily activities. In the last 5 months, due to severe pain and weakness, he became confined to bed. There was no history or suggestive of sensory involvement, bladder bowel dysfunction, dysphagia or dysphonia. He did not report any rash or photosensitivity. There was no history of fever, significant weight loss or night sweats. He also denied any history of significant trauma. Patient was evaluated by multiple local physicians for past few years. He underwent extensive blood investigation and a PET CT scan. However, no definitive diagnosis was established. He was treated symptomatically with analgesics, calcium and vitamin D supplementation for nearly 2 years. Despite these, there was no meaningful clinical improvement and his symptoms progressively worsened. The patient has no significant past medical history and denied any similar complaints in any family member. So, to summarize, this is a 32-year male with progressively worsening proximal muscle weakness for past 5 years, predominantly involving the lower limbs more than the upper limbs, associated with generalized body pain and currently bed bound for last 5 months. So, question to the audience: what could be the differentials? Nice. Anyone else? As the cause remained unclear from the history alone, we will proceed to the clinical examination before discussing the differentials. On general physical examination, he was conscious, alert, well-oriented. There was no evidence of any neurocutaneous markers such as cafe-du-lait spots, and he was vitally stable. On CNS examination, his higher mental function, cranial nerves, and sensory symptoms were within normal limits. On motor examination, there is proximal muscle wasting with a reduced tone in the lower limbs and reflexes are attacked with plantar responsive flexors. This image represents the proximal assessment of the patient. It demonstrates a symmetric pattern of proximal greater than distal weakness, which is more marked in the lower limb than the upper limb. Cardiovascular system, respiratory system, per abdominal examination were normal. Yes.
You mentioned that the patient is bedridden. So how do you explain that?
So,
Patient is bedridden.
so due to the severe pain, he is bedridden and along with the weakness.
It may be myalgia and it may be bony pain both. We'll see in the subsequent slides. The pain was even so severe that in the last 3 to 4 months, as he was bedridden, so he was not even able to turn up in the bed because of the pain, not because of as such, because of the muscle weakness.
So we have a 32-year male with progressively worsening proximal muscle weakness for past 5 years, predominantly involving the lower limbs more than the upper limb, associated with generalized body pain and currently bedbound for last 5 months. On examination, the weakness is symmetric, predominantly proximal, more marked in the lower limb than the upper limb. Plantar responses are flexor bilaterally and with deep tendon reflexive preserve. There is no sensory or upper motor neuron signs and there is no bladder or bowel involvement. So what could be the differentials after the examination? So the main differential remained whether the weakness was neurogenic or myogenic. In our case, the weakness was symmetric, predominantly proximal, more marked in lower limb, sensory examination, reflexes and plantar responses were intact. No fasciculation were present, and which is consistent with a myogenic weakness than a neurogenic weakness. Further differential can be broadly divided into hereditary, inflammatory or metabolic myopathies. In our case, the metabolic myopathies are unlikely given the adult onset and no family history. Inflammatory myopathies are less likely given the absence of skin manifestations and constitutional features. This leaves metabolic myopathies as the most probable cause, which could be due to hyperthyroidism, severe vitamin D deficiencies, hyperphagocytemia, hyperkalemia or hypercalcemia. To evaluate the cause of myopathy, the patient underwent certain investigations. The routine investigations, including the hemogram, renal function test, liver function test, CPK, thyroid profiles were within the normal remit. However, the metabolic bone profile revealed significant abnormalities in the form of hyperphagocytemia and elevated alkaline phosphatase. In contrast, the serum calcium, vitamin D, and intact parathyroid hormones were within normal range. This suggests an underlying metabolic myopathy consistent with hyperphagocytemia. We proceeded to evaluate the bone mineral density using the DEXA scan, which revealed a Z-score of -1.2 in the spine and -3.4 in the left hip, which was suggestive of low bone mass. Further skeleton imaging was carried out, and to discuss the findings, I request Dr. Kavinder Baisla from the Department of Radiodiagnosis to take the discussion forward.
Thank you, Dr. Harman. Good morning. Myself, Dr. Kavinder, second year radiology resident, and I will be discussing the radiological finding of this case. This is PA chest radiograph showing pencil thinning, cortex of bilateral clavicle, and multiple rib fracture of posterior rib depicted by the arrow. On the next image, we can see the X-ray AP view of humerus showing old fracture of medial epicondyle of left humerus. Here the first image is of X-ray AP view of bilateral tibia and fibula showing coarsening of trabeculae. On the next image, there is fracture of left hemisacrum depicted by the arrow. MRI lumbar spine was done showing low signal intensity of the vertebral bodies seen to be hypointense to intervertebral disc suggestive of fatty marrow reconversion. Radiological impression include multiple pathological fracture in visualized skeletal with osteopenia and fatty marrow reconversion in lumbar vertebra. Possibility of underlying metabolic etiology. Thank you. Now I would like to call Dr. Harman to take case discussion forward.
Thank you, Dr. Kavinder, for the detailed discussion of the imaging. I will take the case forward. To recapitulate, we have a 32-year male with 5 years of progressive proximal muscle weakness and generalized body pain who has been bedridden for past 5 months. On examination, the findings were suggestive of a myopathic pattern. The biochemicals showed a significant hyperphagocytemia consisting with the metabolic myopathies. Radiologically, there is low bone mass and multiple pathological fracture suggesting a metabolic bone disorder. The most likely diagnosis in this case would be hyperphagocytemic osteomalacia. Before we move ahead, I would like to give a brief summary on metabolism of phosphorus. Phosphorus is mainly regulated by 3 hormones: parathyroid hormone, fibroblast growth factor 23 or calcitriol, of which parathyroid and FGF23 are responsible for phosphorus excretion in the urine, hence are called phosphatoric hormones. Calcitriol increases the intestinal phosphorus absorption. I will request everyone to remember the roles of FGF23 and PTH, as the upcoming slides are based on this physiology. Whenever we have a low phosphorus, it can be due to three causes: transcellular shift, impaired intestinal absorption, or renal phosphorus wasting. Transcellular shift is less likely in our case, as it has acute presentation in the hospitalized setting and lasts transiently, like refeeding syndrome. We also ruled out impaired intestinal absorption, as there was no gastrointestinal symptoms. After excluding these two, we were left with renal phosphorus wasting, which is more consistent with the chronic presentation, like in our case. So the next step was to confirm whether the kidney was losing too much phosphorus or not. Normally, the renal loss of any electrolytes can be measured using a urinary spot or 25 urinary sample. But the same is not the case for the phosphorus. It has limitations in the setting of chronic hypophosphatemia, where there is low phosphorus and the amount of phosphorus reaching the kidney is also low. As a result, the amount of phosphorus filtered out the glomerulus would be low, leading to falsely low urine phosphorus value. To overcome this, we use TMP-GFR. It represents the maximum capacity of the kidney to reabsorb phosphorus and prevent it from being lost in the urine. In simple terms, it is how well the kidney is conserving the phosphorus. So a low TMP-GFR means that there is renal phosphorus wasting. We calculate the TMP-GFR using the Walton-Bijovich nomogram. The calculation of TMP-GFR is a complex process that requires multiple parameters as shown on the slide. We will not go into the detail of it, and we calculated the TMP-GFR and it was 1.5 mg per deciliter. As per age specific cutoff, normal the TMP-GFR should be around 3.09 to 4.18 at this age group. And our patient's value was 1.5, which is much lower than the expected, confirming the renal phosphorus wasting.
So it just to simplify the fact, this represents that at what level of phosphorus will start appearing into the urine. So normally we have a phosphorus 2.5 to 4.5. In this case, the TMP-GFR is 1.5, means as soon as the blood level goes beyond 1.5, kidney will excrete everything out. So that it will not allow the phosphorus to go up beyond 1.5. So that is what is, and that is why we can see that your TMP-GFR and the serum level of phosphorus are in the same range, 1.5, 1.8. Beyond this, everything will come out into the urine. It's osteomalacia. Rickets happens in childhood age. It's called.
The next step was to identify what was causing this excess renal phosphorus. As discussed earlier, there are two main phosphaturic hormones, parathyroid hormone and FGF23, which both increase the renal phosphorus excretion. So when we see too much phosphorus being lost in the urine, we need to ask which hormone is responsible for it. Our patient's PTH was within the normal limit, so the PTH is unlikely the cause of phosphorus loss. Then we measured the FGF23 levels. His plasma FGF23 was markedly elevated compared to the reference range, confirming FGF23 mediated renal phosphorus loss as the underlying mechanism. The next step was to determine whether the cause was inherited or acquired. Our patient had adult onset of presentation, and when with no family history, inherited causes are unlikely. Amongst the acquired cause, there was no history of iron infusion, renal transplantation, and there is no history feature suggestive of fibrous dysplasia. And confirming the most likely diagnosis in our case would be tumor-induced osteomalacia. To recapitulate up to this point, based on the clinical examination, biochemical findings, and imaging results, the overall picture was consistent with a hypophosphatemic osteomalacia. Further, the renal evaluation demonstrated a FGF23 mediated phosphorus wasting. So at this stage, the most likely diagnosis will be FGF23 mediated hypophosphatemic osteomalacia, likely to be tumor-induced osteomalacia. A brief on TIO. It is a rare paraneoplastic condition characterized by excess FGF23 secretion by small, slow-growing phosphaturic mesenchymal tumors. These tumors can occur anywhere in the body, most commonly in the lower limbs. They overexpress somatostatin receptor SSTR2, which makes gallium-68 Dotonok PET-CT as the imaging modality of choice. These tumors are very small and benign in nature, so FDG uptake would be low. Hence, gallium-68 Dotonok PET-CT is preferred over FDG PET, following which gallium Dotonok PET-CT was ordered. To brief up the findings of gallium dotanol PET CT, I invite Dr. Kaushiki Shukla from Department of Nuclear Medicine to take the case forward.
Thank you, Dr. Harman. I will be taking the discussion forward. To brief of the, I, Dr. Kaushiki from the Department of Nuclear Medicine, will be taking the discussion forward. As discussed earlier, the patient had undergone an extensive workup. As part of that workup, a dotanol PET was done outside. The patient was referred to us by the Department of Endocrinology for review of the old dotanol PET done at the center outside, which I will be discussing as it has clinical relevance in this case. I would like to apologize for the poor quality of the images. The DICOM data or the soft copy was not available. So these are the printed images which were reviewed. On the right, you can see the representative axial sections of the patient, which the arrows indicate multiple tracer ravet fractures at the right scapula, bilateral ribs, and at the left acetabular region. The final findings were faintly tracer ravet fractures in the lateral border of the right scapula, few bilateral ribs, right iliac sacrum, left acetabulum, and upper end of the left tibia. Faintly tracer ravet uptake was noted in lucent areas in head and neck of the bilateral femora, which was likely osteoporotic sequelae. Please note that the tracer uptake in the left acetabulum was reported as a fracture, as it is going to be essential for our case discussion later. Another dotanol PET CT was ordered. This is the maximum intensity projection image of the gallium dotanol scan of the patient with head to toe acquisition. It is showing physiological uptake in the pituitary gland, liver, spleen, both the kidneys, urinary bladder, and this is the site of injection. And you can appreciate a very tiny focal uptake in the right hemipelvis region. These are the representative axial images of the patient, which show tracer ravet bilateral multiple rib fractures, which were pseudo-fractures. This is the corresponding CT images of the patient, coronal, axial, and sagittal sections of the pelvis region. If I tell you that the lesion was in the left pelvis region, would you be able to identify it in these images? No, because the lesion was not easily appreciable on the CT images. These are the corresponding PET CT findings, where we can see that there was a focal tracer ravet intraosseous lesion with small soft tissue component in the posterior column of the left acetabulum, likely representing a mesenchymal tumor. If I compare it to the previous MIP image of the patient, you can see that there was decreased intensity of uptake in the left pelvis region, but it was reported as a pseudo-fracture earlier. As in cases with multiple bone fractures in the scan, as in the case, the culprit lesion can be easily missed or misinterpreted as a pseudo-fracture. The clinical understanding and close departmental coordination was the deciding factor in this case. These are the final findings of the patient. Faintly tracer ravet fractures in lateral border of right scapula, few bilateral ribs, right iliac sacrum, upper end of tibia, which were pseudo-fractures. Focal tracer ravet intraosseous lesion with a small soft tissue component in the posterior column of the left acetabulum, which was likely a primary mesenchymal tumor. After finding the culprit lesion, the patient was referred back to the Department of Endocrinology. Now I would like to invite Dr. Harman to take the discussion forward.
We have established the diagnosis of FGF23 mediated hypophosphatemic osteomalacia, likely tumor-induced osteomalacia. Further, the gallium-68 dotanol PET showed a SSTR avid lesion in the posterior column of the left acetabulum, likely to be a phosphatic mesenchymal tumor. Putting all this together, the diagnosis is tumor-induced osteomalacia, secondary to FGF23 secreting phosphatic mesenchymal tumor, likely to be the left acetabulum. The next logical question was whether we should proceed with a preoperative biopsy. However, in this case, a biopsy posed significant technical challenges. Because of the small size of the lesion and its difficult anatomical location, a preoperative biopsy was not feasible. In fact, in many reported cases of tumor-induced osteomalacia, biopsy is not often performed and definitive treatment is undertaken based on the strong clinical suspicion and precise imaging localization alone. To further confirm the presence of the lesion, we performed contrast-enhanced T1 weighted MRI of the hip. This also showed a lesion corresponding to the exact area identified on the Dotanov PET CT scan. Now coming to the management in our patient. With TIO, we had three options: surgical, medical therapy, or local ablative therapy. Surgery is usually the treatment of choice when the tumor is localized and it can give rapid biochemical cure. However, it is still a major operation and needs careful risk-benefit consideration. There is a risk of surgical complication, including the possible injury to the nearby important structures and joint cartilages. Medical therapy includes oral phosphorus supplementations, which is often difficult to tolerate and requires long-term use. Another option is a borozumab injections, which is expensive and is not easily available in India. Most importantly, both these are supportive treatment, not curative, since the primary tumor remains in place. Local ablative therapy is minimally invasive and done under imaging guidance. It is useful in difficult surgical locations, though there is small risk of incomplete treatment. However, the available evidence is limited and mainly comes from small case reports and small case series. As surgery is the treatment of choice, we refer the patient to the orthopedic department. I request Dr. Vikrant from the Department of Orthopedics to take us through the surgical assessment.
Thank you, Dr. Harmanpreet. Good morning, sir, my seniors, colleagues. I am Dr. Vikrant, and on the behalf of the Department of Orthopedics, I will be discussing the case further. As you can see in this Dotanov PET CT scan, the localization of the tumor has been in left posterior column acetabulum. Now a very important decision to make. In this, complete resection was technically challenging due to deep anatomical location in the posterior column of acetabulum. Also, the lesion was small and hence was not clearly visible on CT, making intraoperative localization difficult. We could have approached this tumor in two ways: the intracapsular approach. However, that would have resulted in articular cartilage damage, disturbing the congruity of the joint, and ultimately necessitating total hip arthroplasty for a 32-year-old young male. Second approach would be extracapsular. However, that would have resulted in extensive bony damage. So, considering the small tumor size, the probability of surgical failure, and disproportionate morbidity, non-surgical management was advised to the primary team. Now, calling Dr. Harmanpreet back.
And last but not the least, we still do not have a biopsy, so it is all presumptive and suspicious. When you go such a big surgery and ultimately we take out nothing, it's difficult to explain the family. So that's another way of looking at the surgical option.
Thank you. Calling Dr. Harmanpreet back to take the discussion further.
Thank you, Dr. Vikrant. As discussed by the Department of Orthopedics, the tumor was deemed surgically challenging and not feasible for safe excision. So, what should be the next line of management in this situation? A multidisciplinary team discussion involving the Department of Endocrinology, Orthopedics, Nuclear Medicine, and Radiology took place. As we discussed earlier, the surgery in this case is surgically challenging and carries significant risk and morbidity. So, the other options were discussed. The medical therapy is a long-term solution and offers limited benefit. It is cumbersome and is poorly tolerated. As discussed, the borozumab, the targeted anti-FG23 antibody, is not available in India and is extremely costly and requires long-term therapy also. Both surgical and long-term medical therapy was not ideal in this situation. So we were left with one reasonable option, that is local ablative treatment. At this time, we went back to the literature to explore the available evidence for RFA in TIO. We came across a case series published by one of our faculty members, which reported encouraging outcomes. This experience gave us confidence to consider RFA as a potential curative option in our patient, for which patient was planned for CT-guided RFA. To elaborate on the procedure and its technical aspects, I would like to invite Dr. Kavinder Baisla from the Department of Radiodiagnosis to take the discussion forward.
Thank you, Dr. Herman. As told by Dr. Vikrant, because of his age, we attempted to preserve the healthy hip joint, which was not affected by the tumor. The patient was referred to us for radiofrequency ablation. But as you can see, the lesion was not visualized on the plain CT. So we used corresponding Dotanock PET CT guided images to approximate the site with the help of adjacent anatomical structure to the best of human calculation. Before starting the procedure, detailed written informed consent was obtained. The patient was then positioned prone on the CT table and spinal anesthesia was administered. Then hydrodistension of the hip joint with saline infusion was performed to mitigate the thermal effect on the articular cartilage. However, hydrodistension for the sciatic nerve was not performed as adequate bony cover was present. The skin entry point was then marked and the trajectory was planned based on anatomical landmark. Then a bone drill was used to reach the target site and an insulated cannula was inserted under CT guidance. And radiofrequency ablation probe with 8 expandable prongs was then introduced through the cannula to ensure adequate coverage of the lesion. Ablation was performed at 90 degrees Celsius with a power setting of 60 watt for 5 minutes as impedance was reached after 5 minutes. 3 additional cycles was subsequently performed. After completion of the ablation, the probe was carefully withdrawn and a sterile dressing was applied. The procedure was well tolerated and uneventful and patient was sent back to endocrinology department. Thank you. Now I would like to call Dr. Herman to take case discussion forward.
Thank you, Dr. Kavinder, for explaining the CT guided RFA procedure. The procedure was well tolerated and patient was discharged on day 7 without complication. He was followed up after 1 month. However, there was no significant clinical improvement during this period, and even the biochemical response was minimal and transient. After the procedure, as you can see, the biochemical remission was not achieved. In view of incomplete remission and persistence of disease, following which case was rediscussed in the multidisciplinary board to assess the further management. After the failure of initial CT guided ablation, we were left with no definitive curative option and had to mainly rely on the long-term medical management on orophosphorus, which had its limitation. We knew the lesion was not visible on the conventional CT and was best localized on the Dotanock PET CT. This led to an important question: could we use the functional imaging itself to guide the definitive treatment? We reviewed the available literature and were surprised to find that there was not a single published case describing PET guided ablation in this setting. Despite the absence of prior evidence and clear guidelines, and in the face of limited alternatives, we made a conscious decision to step into this uncharted territory. Given the strong institutional expertise in PET guided interventional procedures, we we felt confident to extend this approach to this patient. With meticulous planning and full multidisciplinary collaboration, we proceeded with a novel, functionally targeted PET guided ablative strategy. There was no precedent published for PET guided RFA in TIO, which made this approach technically demanding. In addition, the tracer was not available at our institute in 2021, so procurement and inter-center coordination was required. This meant close coordination between the Department of Endocrinology, Nuclear Medicine, and Radiology to ensure precise planning and execution. Lastly, the logistics. The tracer had to be administered at a licensed center outside. Since the tracer is time sensitive and patient needed to be transported, a seamless inter-institutional coordination and precise timing was critical for the success of this procedure.
So sir, in addition to the other limitations, that was the biggest challenge, because in 2021 we did not have a gallium generator in our center. So even the earlier gallium PET was done also in an outside facility. So how do we do that? Because at that center, if the gallium Dotanock is available, but expertise of doing RFA is not available. We have RFA expertise, but we do not have at that time gallium Dotanock PET CT. So it required a lot of collaboration with that center, and those center also kindly agreed to this kind of arrangement. And at the end of the day, when we administered that tracer, it's a radioisotope, as we all know. So there is a time sensitive, sensitive is involved. So the transport of that patient from to that point to this point is also because we need to acquire the image 45 minutes after the administration of tracer. So all these logistics also played a very, very important role in management of this.
Despite all of these challenges, we went ahead with the procedure. I would like to invite Dr. Kaushiki Shukla from the Department of Nuclear Medicine to elaborate on the PET guided procedure.
Thank you, Dr. Herman. While FTG PET-guided interventions are routinely done at our institute, this was the first time we were attempting a unique procedure that had not been done before, which was DOTANOC PET-CT-guided RFA. The patient was injected with 4 millicurie of gallium DOTANOC outside and transported to our department, where a multidisciplinary team was formed to perform the procedure, comprising of the Department of Nuclear Medicine, Radiodiagnosis, Anesthesia, and Endocrinology. Proper consent was taken and the procedure was started under spinal anesthesia with vitals being monitored at every step of the procedure. The regional PET of the pelvis region was taken. The lesion was localized and marked. The arrows show the joint cartilage and the sciatic nerve that needed to be preserved. Skin markings were done after identifying the sciatic nerve, and we proceeded with the RFA. Hydrodistension of the joint was done. An insulated cannula was inserted at the target site, followed by a multi-pronged RFA probe. 2 cycles were administered at 60 watts at 90 degrees Celsius for 5 minutes. PET-CT images were acquired to check for remnant activity at the target site, and again the tip was readjusted and 2 other cycles were administered using this same protocol. Multiple cycles were done with overlapping zones to achieve complete ablation of the lesion, with charred tissue being checked for the activity with the survey meter after every cycle, the basis of which was that the charred tissue or necrosed tissue would not have any radioactivity left, confirming in real time that the procedure was going in the right direction or not.
So as we just mentioned, it was uncharted territory for us. So in fact, we were not knowing at that time that after how many cycles actually the PET activity will get disappeared or not. So it's a functional tumor. We cannot take the risk of being a second failure. So that is why, in fact, we did the 2 more additional cycle. Maybe it is little too much, but we have to ensure that this time the patients get cured or get at least benefited from the procedure. So there is no precedence. So that is why the last 2 cycle was done, just to ensure that we achieve the better outcome this time.
These are the pre-procedure, during procedure and post-procedure images. We can appreciate that the intensity of tracer uptake has markedly reduced at the target site, indicating completion of a successful procedure. Procedure was well tolerated.
Can we go back? So that is another utility what we found is, rather than CT guided or CT guided RFA, where we will come to know the failure or success of the procedure 3 days or 7 days after the procedure when we do phosphorus. This probably we realize actually more useful tool for us for real time monitoring whether we have achieved our desired outcome or not. Because if we can ensure that there is an absence of uptake in the culprit lesion, probably we have dealt the lesion in a wholesale manner, and mostly there is no residual disease left. So that one additional utility in addition to localization we found out about this procedure.
Yeah, and I think there are several unknowns over here because this is not a tried and tested procedure. Like if the DOTANOC activity is decreased, will it decrease within minutes? Will it take several days to decrease? Will it take several weeks to decrease? That is all, uncharted territory, as you said. So probably in hindsight, the CT guided or localization and the RFA at the first time was not done at the right place, and the DOTA PET localized our probe to the right position, correct?
Yes, but what we did, sir, even with CT guided to the best human possible condition, we took all measurements meticulously, the distance and everything. So approximate site was targeted, and which actually was shown, because that's the only thing that was available and the evidence was available. We did not have anything else.
The procedure was well tolerated. No immediate complications were seen. Minimal or no tracer uptake was seen in the suspicious lesion. and the patient was shifted back to the endocrinology ward with proper analgesic cover. I would call Dr. Harman to take the discussion forward.
Commenting on your the question that activity disappeared by its own and not, we can see the activity is still there in the bladder. So if it is because of just disappearance, because of the time, then it will not be there in other place also. So that is one.
Thank you, Dr. Kaushiki, for explaining the PET-guided RFA procedure. After PET-guided RFA, the phosphorus and FGF23 normalized within 1 week, and TMP-GFR also improved, confirming correction of renal phosphorus wasting, representing clear biochemical remission. Subsequently, patient was discharged after 1 week. Over 4 years of regular follow-up, the phosphorus has remained stable, FGF23 suppressed, and no activity of disease reoccurrence. At 3 months post-ablation, the patient demonstrated marked clinical improvement, and there was significant reduction in musculoskeletal pain and proximal weakness. He regained ability to sit up independently and showed an overall increase in strength. By 12 months post-ablation, the improvement was sustained, and patient was able to walk and resume daily activities without pain or weakness. Now patient is able to walk independently and perform his daily activities. Follow-up gallium dotronok PET scan was performed after 1 year, and compared to his previous scans, there was interval resolution of dotronok uptake with no reoccurrence of the lesion. Similarly, we can see the patient was able to walk and resume daily routine activities without pain or weakness. Here we can see patient is engaged in his occupational work without pain or weakness. Now I invite Dr. Saloni Jan Ma'am, Assistant Professor from Department of Endocrinology, to take the discussion forward.
Just as sir was saying that it was an old case, but since it was an uncharted territory, we wanted to make sure that result we have achieved has to be sustained, because there is 20% recurrence rate even after surgery. So we were not knowing what is going to happen after PET guided RFA, where it's a temporary remission, long-term remission. So now we can say, fortunately, that after 4 years, patient is still remission and doing his things normal.
So good morning, respected chairperson, esteemed faculties, colleagues, and my dear students. So as we already know, now from this case, we came to know an entity called as tumor-induced osteomalacia, which is rare yet important. And I am very proud to share that not only we provided cure to the patient, but we also reported this report in one of the reputed endocrinology journal. And not only this, it was selected as the article of month and was on the cover page of one of the reputed endocrinology journals. Now, if you ask me, why this case? Because this is just not a rare disease. It is a devastating, but yet completely reversible metabolic disease. Tumor-induced osteomalacia silently cripples the patient. They develop fractures, and in fact, 90 to 95% actually these patients are misdiagnosed initially. And what makes this case even more remarkable is that it is one of the first reported dotronok PET-guided RFA ablation cured patient. Now, from take-home messages, as we know, we knew about TIO, that surgery is the first line of treatment. We went into an uncharted territory. But I want everyone to point out the fact that whenever we talk about metabolic bone disorder, we always talk about calcium. We measure calcium, we supplement calcium. But it is not just the calcium. Here, the phosphorus is the central player. If I say so, even for the proper mineralization of the bone, the phosphorus is the main mineral which is responsible, and bone will be poorly mineralized in those patients even if the patient have normal calcium. To conclude this, I really want to extend my thanks to the management of Mahatma Gandhi for an unremarkable support for the patient, to all the department for integrated support, like radiodiagnosis, nuclear medicine, neurology, orthopedics, anesthesia, biochemistry, to CCR review committee, to my dear nursing staff, transportation team, and the last but not the least, for the patient and his family for trusting us.